Hello and welcome back to A Doctor's Diary, practical medicine for everyday life. Today we are talking about brucellosis, an important zoonotic infection that clinicians should recognize, especially in patients with travel history or exposure to livestock and unpasteurized dairy products. Brucellosis is caused by bacteria of the genus Brucella. The species most commonly associated with human disease include Brucella melitensis, Brucella suis, Brucella abortus, and less frequently Brucella canis. These bacteria are small, gram-negative, non-spore-forming organisms that are sensitive to heat and disinfectants, but they can survive for days to weeks in the environment, especially in milk, soil, dust, and water. Brucellosis occurs worldwide, but it is most common in regions such as the Mediterranean area, the Middle East, Africa, Asia, and parts of Central and South America. In countries like Germany, most reported cases are imported infections, often associated with travel to endemic regions, particularly Turkey and surrounding areas. The main reservoir for Brucella species is livestock. Brucella abortus is commonly found in cattle, Brucella melitensis in goats and sheep, and Brucella suis in pigs. Humans typically become infected through consumption of contaminated, unpasteurized dairy products, especially raw milk or cheese. Infection can also occur through direct contact with infected animals, inhalation of contaminated particles, or through broken skin or mucous membranes. Laboratory exposure is also a known risk factor. Once inside the body, Brucella bacteria are taken up by macrophages and transported to nearby lymph nodes. From there, they can spread through the bloodstream and infect multiple organs. The spleen, liver, and bone marrow are commonly affected, and chronic infection may lead to the formation of granulomas in affected tissues. The incubation period usually ranges from 5 to 60 days. Human-to-human transmission is extremely rare, but it has been reported through breastfeeding, blood transfusion, bone marrow transplantation, and sexual contact. Clinically, brucellosis is known for its highly variable presentation. Many infections remain subclinical and are detected only by serological testing. When symptoms occur, they often begin gradually or suddenly with fever, fatigue, headache, nausea, and characteristic night sweats. The fever may follow an undulating pattern, with several days of fever alternating with symptom-free intervals. If the disease is not recognized and treated properly, it may progress to a chronic form lasting longer than 1 year. Chronic brucellosis is associated with persistent fatigue, sweating episodes, and depressive symptoms. Localized infections are common, particularly involving bones and joints, acroilitis, arthritis, or bursitis. More severe complications may include meningitis, endocarditis, epididymo-orchitis, and, in rare cases, pancreatitis or peritonitis. Hematologic abnormalities such as anemia, leukopenia, and thrombocytopenia may occur when bone marrow involvement is present. Although the overall mortality rate is relatively low, serious complications such as Brucella endocarditis remain the leading cause of death in untreated cases. Diagnosis of brucellosis can be challenging due to the nonspecific nature of symptoms. A detailed medical history, including travel history and dietary exposure, is extremely important. Laboratory confirmation is essential. Blood cultures should be taken repeatedly, ideally during febrile episodes and before starting antibiotic therapy. Depending on the clinical presentation, other samples such as bone marrow, cerebrospinal fluid, urine, or tissue samples may also be used. Serological testing is widely used and includes detection of specific IgM and IgG antibodies. A significant increase in antibody titers over time strongly supports the diagnosis of acute infection. Molecular methods such as PCR are increasingly used for rapid detection and species identification. Treatment of brucellosis requires combination antibiotic therapy to prevent relapse. The standard regimen usually includes doxycycline combined with rifampicin for a duration of 6 to 12 weeks. In cases where doxycycline is contraindicated, such as in children or pregnancy, cotrimoxazole combined with rifampicin may be used. Monotherapy is not recommended due to high relapse rates. In severe cases involving bones, joints, or heart valves, surgical intervention may be necessary. Prevention of brucellosis focuses mainly on controlling infection in livestock and avoiding exposure to contaminated products. Pasteurization of milk and dairy products is one of the most effective preventive measures. In endemic areas, consumption of raw milk or unpasteurized cheese should be strictly avoided. Individuals working with animals, such as veterinarians or farmers, should use protective equipment and maintain strict hygiene practices. Currently, there is no approved vaccine for humans in many countries, although vaccines may be used in animals to control disease spread. In summary, brucellosis is a zoonotic infection with diverse clinical manifestations and a potentially chronic course if untreated. Early recognition, appropriate laboratory testing, and prolonged combination antibiotic therapy are essential to prevent complications and relapse. Brucellosis may not always be the first diagnosis that comes to mind, but in the right clinical context, especially in patients with travel history or exposure to unpasteurized dairy products, it should always be considered. If you found this video useful, consider subscribing to A Doctor's Diary, where complex medical topics are transformed into practical clinical knowledge you can use in everyday practice. See you in the next episode.